First, I want to thank you for coming out today. And second of all, thank you for giving me an opportunity to get out of New York City and get into the mountains. I had a unexpected but beautiful drive here from Charlotte earlier today because I missed my connection. But it was an awful lot of fun. It is nice to get outside of New York City. Let me say about Dean Wyckoff here, we were classmates, but because he was so helpful in helping us putting together the Live Sugar-Free campaign, I won't tell you any of the stories that I know about him from our medical school class. Let me just say that he was one of the more lively members of the class, and we appreciated him. I was very fortunate to be the health commissioner in New York City for 4 years during the time when Michael Bloomberg was mayor. And that was a time when we had a lead elected official who really believed in public health and gave us opportunities to do things in public health which we ordinarily don't have a chance to do. And so I'm going to talk about the things that were done by myself working with Mayor Bloomberg and also by my predecessor, a man named Tom Frieden, who was health commissioner there from 2002 to 2009, and then went on to be the director for the CDC. And you've probably seen him, especially during the Ebola crisis in his role at the CDC. I'm going to give you a sense for what the problems as in public health in New York City as he saw them when he first came in, and the way that he drew lessons from the history of public health about how to approach those problems, what was done, and what was the result of that. So I guess I have to show this, but I have no conflicts, but I do have opinions. So just a little background around New York City. It's a big city there, very packed people, place. Most people think of New York City, when they think of it, they think of Manhattan. But in fact, Manhattan is geographically a very small portion of this 5-borough city. You see the other boroughs there. Overall, it's about 8 million people. If you count the metropolitan area, that's 20 million people, so it really is a mega city. The city does not have an ethnic majority population. If you look there, the largest ethnic group there, or racial group, is non-Hispanic whites. That's 33%. So it's a very diverse city, and close to 40% of the people there are foreign-born. So an awful lot of people come into New York City and then go out of New York City. The city existed as a political structure before the state did, and so it has the ability to write many of its own laws which other places don't have. This is its home rule. So there's a mayor, there's a city council, which acts like a state legislature in many ways, and there's also a board of health, which has been established in the 1800s as a committee of health experts that are appointed by the mayor with consent of the council, and that can, within the area specifically of health, can pass rules which have the effect of law. So that provided an opportunity for the sort of things that we wanted to do. And then the health department grew out of the need for the Board of Health to implement some of the rules that it put in place. And that has grown over time to a very large agency, 5,000 employees, a budget of $1.6 billion, doing an awful lot of things which most people have no idea about, which is sort of invisible to the public. Birth and death certificates, they're responsible for sanitation. The school nurses in the city public school system all are health department employees. They also provide the medical services in the very large city jail system, many, many different functions that most people don't think about. And that probably don't have that much impact on health when you get right down to it. But when my predecessor, Tom Frieden, came into an office as health commissioner, he had to face this problem, which was a national problem, which is that our health in this country is not good. We are the wealthiest country in the world, but we are far from the healthiest. As a matter of fact, among high-income countries, our life expectancy is close to last. And it wasn't always the case. In fact, we're losing out over time. The rest of the world is surpassing us. And so if we want to improve our health and be the healthiest country in the world, we're going to have to do something pretty fundamentally different from what we've been doing in the past. And our poor health statistics are happening at the time when we are spending twice as much as other high-income countries for health care. So it certainly is not for lack of health care that our health statistics are as bad as they are. So when Tom Frieden first came into office, He started out by looking at data, which is what we do in public health. And he looked at the leading causes of death and got something that was sort of like this back in 2002. And for those of you who looked at health statistics, you won't be surprised by this. You see the number one killer is ischemic heart disease. That's the form of heart disease like heart attacks that you're most familiar with. If you look on down this list here, you'll notice that there's a pattern. You have heart disease, you got cancer, chronic lung disease, diabetes. These are chronic diseases. That is to say, diseases that develop over years or over decades from exposure to something that's not healthy for you. And it may seem like that's kind of the natural order of things, that we're going to die of chronic diseases. But if I were to show you this graph from, say, 200 years ago, it would be completely different. This list would be dominated by infectious diseases like tuberculosis and cholera and yellow fever. And those diseases have now disappeared from the list of leading causes of death. And somewhere in there, then, there is a lesson for how we can try to tackle these diseases. So I want to go back in history then to that time and try to draw those lessons, and then I'll come back to this. So this is a composite graph I have of mortality rates. Really, it was in major cities over close to a 200-year period. So this period in the 1800s, you can see the mortality rates were much higher than they are now, several times higher, in fact. And there were these big spikes. And I've labeled this acute epidemics. And if notice just while we're on this graph that how much mortality rates fell from, say, 1850 to 1900, and then further from 1900 to 1960. If you look more closely in New Orleans specifically, which was a major city back in the 1800s, you can see what those spikes are. They represent epidemics of cholera and yellow fever and smallpox. So this was a time when it was the early days of the Industrial Revolution. People were, for the first time in history, living in crowded cities. They moved close to where the factories were. They were packed into small houses and apartments, 15 people into a room, no running water, no sanitation, no ventilation. This was a perfect setup for spread of infectious diseases, both gastrointestinal diseases like cholera and respiratory diseases like tuberculosis. This is a term that's been used for this, that cities were hives of contagion. And that was the public health crisis of its time. Now, this problem was seen not just in this country, but all around the world. And it was noticed at the time that poor people were more likely to die than wealthy people from these problems. And it was sort of understood by the experts of the day, through, let's say, 1820s and 1830s, that it was their own fault. That poor people were sick because they were intemperate in what they ate and what they drank, because they weren't necessarily religious enough, that they were just sloppy with their own behavior was the problem, and that our solution was going to be to teach them to behave in a better way. But there was one person who had a different approach to this, who was one of my heroes in public health. He was over in England where they had the similar problem. A guy named Edwin Chadwick. He was named as a poor law commissioner, where they had a poor commission in England to figure out what to do with the problem of all these poor people getting sick and not being able to work. And so they were dropping out of the labor force. And he said, actually, I don't think it's their fault. I think the problem is that they live in unsanitary conditions. And that if we give them sanitary conditions, they're going to be healthy, and then they'll be more productive workers, and there'll be less of a drag on society. So I think they should have, that the solution is giving them better sanitation, and I think that the government ought to take responsibility for doing that. That was a radical idea. First of all, that sanitary conditions were the problem rather than the people themselves. And second, that the government should actually step into this very personal issue of health and try to protect people's health. He wrote these ideas in this book called Report on the Report on the Sanitary Condition of the Laboring Population of Great Britain, recommending this. It was a very, very radical notion at the time. The other poor law commissioners, they distanced themselves from him. They didn't want to have anything to do with this guy who was stirring up trouble. And he proposed a public health act for England where the government would raise taxes and use that money to provide sanitation. It took him a few years. Taxes weren't any more popular then than they are now, but ultimately the law passed. And England, for the first time, put in sanitation, and took responsibility for the health of its population. And those ideas then spread across the Atlantic, and you started to see in this country also reports on the sanitary condition of, say, Massachusetts and other major cities. And out of that came the sanitary revolution, what we now call the sanitary revolution. That we saw building of city water and sewage systems. We saw regulation of neighborhood and housing conditions, so no longer were there 15 people packed in one little room with no ventilation. And also at this time, the public health field was very much aligned with social reform movements. Things were happening at the time: unionization, child labor laws, suffrage. All these were also responses to the problems that were seen for the first time in the Industrial Revolution. And the result of this, going back to that graph I showed you a bit ago, between 1850 and 1900, mortality rates fell close to 40%. So probably the greatest improvement in human health in history happened as a result of this change in sanitation. And at the core of that is the idea that people are healthier if you put them in healthy environments. That environmental change is the way to solve a problem rather than just telling people, okay, you ought to be healthy. And so that is the central idea to public health, which we can apply to today's health problems. And so the challenges facing Tom Frieden and the Bloomberg administration when he came in is, what are the environmental ways to fight these chronic diseases? That's sort of issue number one conceptually. And second, what can the city government do given the authority that it has? So getting back now to what the health problems are, he was looking at these leading causes of death, and he noticed another pattern here. And that is that there are certain risk behaviors and exposures that underlie more than one of these causes of death. So smoking increases your risk of ischemic heart disease, number one. It increases your risk of lung cancer, number two, and increases your risk of chronic lung disease, number four. And you could think about other things like unhealthy diet and physical inactivity, which underlie more than one of these problems. And so he said, well, how about if rather than looking at the diseases that kill people, if we tally up our deaths according to the risk factors that lead to the diseases that kill people? And there was no standard way to do that. He did it just sort of, on the back of an envelope. But now there are some attempts to do this at a national level, to say how many deaths we can attribute to different behaviors and exposures. And this is the best data that's available now, the best estimates. And by this estimates, actually the number one underlying killer in America today is unhealthy diet. In all the different ways that diets can be unhealthy. Too much saturated fat, too much sodium, too much sugar, whatever, and smoke, and that's more than 600,000 deaths. Smoking would be second here at maybe 450,000 deaths. And so Tom Frieden looked at these and said, well, okay, the unhealthy diet, he wasn't totally convinced that that was something he should take on first, so he said, I'm going to focus on smoking first. And then a little later, he took unhealthy diet, saying that these are the things which are going to be the key to reducing mortality rates in New York City and improving life expectancy in New York City that are going to have the greatest impact. And his way of approaching that was through environmental change. So he said, okay, we're going to take on smoking through environmental change. How did he end up doing that? In the end, it boiled down to three things to fight smoking. Number one was pretty obvious from anybody who knows anything about economics, and that was he raised the tax on a pack of cigarettes. I say he, but actually it was the whole Bloomberg administration, and later the state government got in on it as well. But if you look here at the 2000, you see this tiny little sliver there. That's the tax on a pack of cigarettes applied by New York City, 8 cents per pack. And so in the first few months of administration, they raised that from 8 cents to $1.50 per pack. And the state heard about that, and they raised theirs to $1.50. So within the first few months, this was after 9/11, and the economy of New York City was in the tank, and they needed to raise some sort of tax revenue, and this was one way to do it. So they ended up more than doubling the tax on a pack of cigarettes. That's a pretty big jolt to the system. It worked so well that later there were more increases at the state level and at the federal level. So by 2010, the total tax on a pack of cigarettes in New York City is $6.86. That means if you go into a bodega in New York City right now and try to order a pack of Winston's, you're going to pay $12, okay, compared to about $4 back here. Big difference, and it had a big impact on smoking rates, which I'll show you in a minute. So that was thing number one. And it showed the principle that economics apply even to an addictive drug, right? Nicotine is an addictive drug, but even so, when you raise the price, people buy less and smoke less. The second thing he did was make the bars and restaurants and other workplaces smoke-free. Much of America is like this now, but back at that time, people smoked in restaurants, people smoked in bars. Bars were as much a place for smoking as they were for drinking. And the idea that we would pass a law that says you can't smoke in a bar was a very radical and very unpopular notion. It was somehow wasn't the government's right to do that. But Tom Frieden recognized that, first of all, the people who worked in bars were suffering in their health, the waitresses and waiters and bartenders, and they didn't have the option to go somewhere else. And so this was a workers' rights issue, number one. It was also that secondhand smoke was bad for other patrons of those establishments. And third, that allowing people to smoke in a bar established the acceptability of smoking. This is the number one killer in New York City, number one killer in America. We really don't want to send that message. So they ended up passing a smoke-free bar and restaurant rule. As they went through this, though, that the claims were that the bar and restaurant industry would suffer tremendous loss of sales as a result of this rule. People would go to New Jersey to go out to eat or to go to a bar. We wouldn't even have tourists come here to New York from Germany or from the rest of Europe because they knew they couldn't smoke in a bar. It was going to be just ruin the economy of New York City. Well, he didn't buy that. Mayor Bloomberg didn't buy that. They passed the rule. And not only did people not go to Westchester or New Jersey to go out to eat, people started coming into New York City to go out to eat without having to breathe in secondhand smoke. And so fairly quickly afterwards, New Jersey and Connecticut and upstate New York, they passed their own smoke-free rules. And not only did the tourists continue to come to New York City, but the idea of smoke-free bars and restaurants traveled to Europe. So very quickly after this, people from Ireland came and saw how we did it, and they passed a smoke-free rule in Ireland, and then it spread across pretty much the entire Europe now has smoke-free rules. The third thing he did was counter-advertising. We know that the tobacco industry figures out a way to provide a very positive image of smoking. You know, it's sexy, it's sophisticated. So, well, maybe should give people a sense of what smoking really does, which is to make you sick. And so they ran a series of ads, including these, they're testimonial ads, when they had real smokers talking about their health problems. This was a guy named Ronaldo who had his larynx removed from laryngeal cancer. So he had a hole in his throat. And he was otherwise healthy, but he couldn't speak unless he had a little electronic gizmo under his throat. And he couldn't even take a shower without worrying about choking. And so his quality of life was not all that wonderful. And people watching this were hit really hard by this. And when the Ronaldo ad came on the air, the number of calls that came to the health department with the request to help quitting skyrocketed. And we saw particular drop-off in smoking rates in Hispanic men. And Ronaldo is a Hispanic man. So these ads worked. And together, the anti-smoking program was incredibly successful. So when the Bloomberg administration came in, the percent of adults who smoke in New York City was about 21.5%. It had been that way for a decade. With the taxes, with the media campaigns, with the smoke-free air rule, it bottomed out at 14%. It ends up being about 400,000 fewer smokers in a city of this size. Now, rough rule of thumb, 1 out of 3 people who smoke consistently dies of smoking-related health problems. So if we got 400,000 people to quit in a short period of time, that means we might have saved 100,000 plus lives. That's a lot of lives, okay? And it shows that a few policy changes to create a different environment around smoking can have a big payoff. So that's smoking, all right? What about a healthy diet? This was a lot more complicated. How do you create a healthy food environment? Well, I'll talk about a number of things that we did, starting with things that were, some of which were relatively small, some of which were bigger. But here's one that we did that was almost unique to New York City, but it was fun, so I want to talk about it. And that is in New York City. If you've been there, you'll know that there are street vendors that sell everything from women's handbags to hot dogs. And there actually it's regulated by the city council. There is a cap on the number of people who can have permits to vend things on the street. And the health department said, and there's a long waiting list for people who want to have permits to sell something else on the street. The health department said, well, we don't have enough access to fruits and vegetables. How about if we raise that cap to say that for the new permittees, they can only get a permit if they agree to sell fruits and vegetables, and they agree to sell those in underserved neighborhoods like Harlem and the South Bronx, and places where people have high rates of diabetes. So we did that, and we didn't know whether people would do that. It may not be such a good business move to try to sell, carrots on the street in the South Bronx. But we ended up issuing 500 permits. On any given day, about 250 of them are on the street. And we evaluated that, and we found that not only are there more carts selling fruits and vegetables, but that the brick and mortar stores in those neighborhoods started selling more fruits and vegetables to compete. So we increased access to healthy food with one thing which didn't cost the city anything. We also did a program called Health Bucks, where we gave people who were on the food stamp program these $2 coupons, which can only be redeemed for fruits and vegetables if they go to a farmer's market. And a few $100,000 worth. In a city like New York, that's small, but it did introduce people who were at lower income to a farmer's market where they could get healthy produce. And the third thing we did, this is small, I'll acknowledge that, is we try to see all the little corner stores in New York City, which sell mostly unhealthy food, and it's not that much different in rural areas. We worked with them and said, if you have a healthier mix of products, we can put the sticker on your door that says, shop healthy, and we'll tell people they should go there. And we also worked with distributors and identified items that were healthy so that when the corner stores went to buy their items to put in their store, they knew those items that we would consider to be healthy. Didn't cost us really anything. It's not a huge program, but for some of those corner stores, they now have a healthier mix of items than they did before. So these were things which I have to say were not huge. They're sort of nibbling around the edges of the problem, but an attempt to give people greater access to healthy food. But we still had this big problem, a problem which is a national problem, and it did not spare New York City, and that is the obesity epidemic. This is just data from telephone surveys that we do every year in New York City, and getting people, they tell you their height and weight, and by that you can estimate the percent that are obese, and it underestimates their obesity rates, but gives you a sense of the trends. Obesity rates are rising. Diabetes now, close to 11% have physician-diagnosed diabetes. That means that there's another, say, 2% that have diabetes and nobody knows it, so maybe 1 in 8, 1 in 7 has diabetes. It's a huge problem. And diabetes is so common these days that people almost feel like it's a natural part of the aging process. But it didn't used to be that way. If you go back to 1960, about 2% of the population had diabetes. So it's a huge problem that happened, and we're not going to solve that problem unless we solve the obesity problem. And our approach until this point to solving the obesity problem wasn't very successful, okay? And this is more or less captures in one picture what our problem was. We were out there saying, yep, obesity is a problem, and the food industry is out there saying, yep, go to McDonald's to get all the stuff that you really shouldn't be eating. They said, well, we ought to be able to do better than that. And so we at least started simple and said, there are some people who are trying to be conscious about how many calories they take in. So when they go to a chain restaurant like a McDonald's, at least you ought to have it be aware that they can see how many calories are in each item and they can make smarter choices. Not everybody's going to do this, but for those that do, we want to have that information available to them. So the Board of Health, that I mentioned earlier, regulates restaurants in New York City. So the Board of Health could pass a rule that said the restaurants have to put on their menus and menu boards a calorie count, like this here, this 510 calories for the quarter pounder. And so the rule was passed. It was not at all popular in the restaurant industry. We were sued twice, but it ultimately went into effect, and it actually got included in the Affordable Care Act, and so it will, in I think about a year, go national, so you'll see these calorie counts on menus and menu boards all over America. And here's what the evaluations show. About 15% of customers use them, and those that do buy about 100 calories less. So a small effect, not huge, not itself going to turn around the obesity epidemic. So it's good, but we knew we needed to do more. And when I came in, I saw the problem as mainly this, that for all of our concern about people's lack of access to healthy food, in fact, the greater problem is the overabundance and the overpromotion of the unhealthy food. All the stuff which nutritionists tell us we shouldn't eat is available in stores everywhere. It's available in snack counters everywhere. It's available and even school vending machines. And it's really cheap, right? For $2, you can get yourself a 3-liter bottle. For even 25 cents in a bodega in the South Bronx, you can get yourself this little quarter water. This is not good. We didn't know how to tackle all of this, but we did think we could take on one particular piece of it, and that was sugary drinks. And evidence was coming out that sugary drinks were particularly important to obesity, although not the entire problem. And I'm sorry, what I'm showing here is the different portion sizes that were available and how much sugar is in each of them, which is pretty mind-boggling if you just look at the pictures. But it also could be seen as sort of the progression of the portion sizes that are sold to people over the years. When I was in elementary school, a standard size bottle of Coke was 6 3/4 ounces. If you ever looked at one of those bottles like now, I mean, it looks like it disappears in your hand. It looks so tiny to us. But that was the standard bottle. And even at that time, that was more than one, some people could drink in an entire setting. Then when I was in high school, the standard container was a 12-ounce can. And then by the time I was in medical school, it was getting to be around a 20-ounce bottle. So that more or less, there was a tripling of the portion sizes that were sold to us, and that more or less was followed by a tripling in consumption from 70 calories per capita per day in the whole country to 190 calories per capita per day. And this more or less follows the incredible growth of the obesity epidemic, which really took off around late 70s or in 1980 and hit its peak, it was peak anyway in the early 2000s. So we knew that sugary drinks were not the entire problem, but they were a big chunk of the problem. And if we could get that consumption to get back down to where we were here, we might see some turnaround in the epidemic. And so we said, well, how can we take the lessons we learned from smoking and apply them to sugary drinks? So I showed you the ad on the counter ad on smoking. I said, well, we can do counter ads on sugary drinks as well. And we found in focus groups of people in New York City that people thought, well, you can gain weight with hot dogs and French fries, but you can't gain weight on a liquid. How can a liquid turn to solid in your body? So we said, all right, we're going to give people an image showing this stuff going from a liquid into fat in your body. Pretty simple concept, and it was also, we deliberately made it pretty disgusting because people have been sold a very positive image around sugary drinks. You know, Coke is happiness, and so we want to show actually this stuff is something that's going to be something you don't really want in your body. It started out as a Subway campaign. Later on, as more funding became available, we did some ads on television, but we kept with the slogan, "Are you pouring on the pounds?" and with images that were sort of like this. So there was counter-advertising. And we said, what about some of the other things we did in smoking? What about a tax? The tax on a pack of cigarettes worked pretty well. So we proposed a tax on sugary drinks. We proposed it to be 1 penny per ounce, so that the more volume that you bought and drank, the more tax you'd have to pay. So it gave people just the right incentive to either reduce their portion size or to switch to a diet beverage or to water. And we estimated it would raise the average price about 20%, reduce consumption 15 to 20%. We took this to a researcher at Columbia and said, you know, what would the health impact of that be? And she estimated in New York State, over 10 years, it would save 37,000 cases of type 2 diabetes and save $2 billion in healthcare costs. Not bad, okay? I actually think that this is a conservative estimate. The point is the health impact of this would be big. Well, it wasn't, so we loved it. It wasn't that popular with the soda industry. That probably doesn't surprise you. So they had a full-on effort to kill the soda tax proposal. This was just the public aspect of it. You saw posters like this around the city. There were also ads that they ran against it on television. They also put an awful lot of money into lobbying. Put money into lobbying in the Capitol in Albany, because this rule needed to go through the state legislature. We couldn't do it in the city. But the idea traveled to Washington as the health care reform bill was being debated. This was suggested as one of the potential funding sources. And so the soda industry also lobbied Washington to kill the soda tax. So this is just where I had data available. This is how much money Coke, Pepsi, and the American Beverage Association put into lobbying in Washington. And we saw this nice peak there in 2009, right when our proposal came through. And sure enough, they killed the idea of the soda tax in Washington. They killed the idea in Albany. So no soda tax, at least at that time. So we kind of, and we'd had a pretty big effort on this, so we kind of pulled back and licked our wounds a little bit and said, well, how else could we attack this problem? If there was any legitimacy to the charges against the soda tax from the soda industry, was that it was going to be taking money from poor people. And poor people could choose to not buy sugary drinks, but there was some truth to that. So, well, what do we do that wouldn't have that financial impact, but still might reduce consumption of sugary drinks? So, well, at the very least, the government shouldn't be subsidizing sugary drinks in the middle of this obesity epidemic. And so we looked into the food stamp program, which is now called the SNAP program, for Supplemental Nutrition Assistance Program. And the SNAP program, for those who don't know, provides benefits which are accessible through what's like a credit card called Electronic Benefit Card, or EBT. It means that when people go to a grocery store, they can use those benefits to buy almost anything in the grocery store, but not everything. Okay, you can't use electronic benefits to get cigarettes, to get beer or other alcohol, or to get pet food or aluminum foil, which are not food, or to get prepared food. So you can't get a deli sandwich at the deli counter at the grocery store, or a rotisserie chicken at the grocery store. Can't get that. So we said, we don't think that a supplemental nutrition assistance program should be buying the one item that is the biggest contributor to our number one nutritional problem in America. So why don't we just say sugary drinks are also on the list of things you can't use the SNAP benefits for? So then we won't have this. The convenience stores that are drawing people in and trying to get them to get these big 2-liter bottles of soda, which is really bad for them. So we proposed that exclusion. And then people would get the same dollar amount of benefits they were getting before, but they would just be using them to buy something which is healthier. Well, that proposal needed to be approved by the agency that oversees the SNAP program, which was the USDA. They were lobbied heavily by the food industry, and they turned us down. So now we're 0 for 2 on those policies. So then we said, well, what can we do that doesn't require the approval of the state legislature, doesn't require the approval of Washington, is not going to be subject to the lobbying of the soda industry? And we started thinking about portion size. I showed you the growth in portion size over time, and it's just worth pointing out that back in the 1950s, a 16-ounce bottle of soda was advertised as being big enough to serve a family of 3. And there were some pretty disturbing studies that had came out around this time that showed that when you gave people a food or a beverage in a larger container, they just ate more and didn't even notice it. And it shows that we're much more passive consumers of what are given to us than we recognize. Almost you give people something twice as much, they feel fine, they eat it, they have no concept that they have eaten twice as much. And so we said, well, maybe if we just give people as much access as they want to sugary drinks, but put it in smaller containers, then maybe people won't get that refill, and maybe they won't drink quite so much. So we came up with a proposal that you probably heard about, which was to say that through the New York City Board of Health, which regulates restaurants, those restaurants, they could sell sugary drinks in as much volume as they want, any way they want, but the container, the cup size, had to be no larger than 16 ounces. That idea generated an awful lot of attention. It was labeled a soda ban, even though we weren't banning anything. It was a regulation on container sizes. And even at that, the container size 16 ounces was pretty generous. It was big enough to serve a family of 3 not too long ago when we were a lot healthier. But it was presented as we, bureaucrats, that's me by the way, are interfering with freedom of choice. Bureaucrats were telling you what size beverage to buy. The soda companies hated this idea. They had a full-on public relations campaign against it, and they're pretty good at using the mass media. And so we didn't look that good in the mass media in this. I'm not sure what your opinion was, but most people around the country thought we were interfering with freedom of choice. And so the Board of Health passed this. We were sued. It ended up, and I wanted the question, does the Board of Health have the authority to make this rule? It ended up going to the highest court in New York State, and we lost in a split decision. I still think they're wrong and we were right, but the fact of the matter is that the rule did not go through because of that the soda companies beat us on this one through a lawsuit. But, so now that's loss number 3. But the publicity we got for this kept on talking about soda as something that contributes to weight gain. And so even though we looked bad in the discussion, it kept on reinforcing our message that you probably shouldn't be drinking so much soda. And we got things like this that appeared, right? So this is free advertising for public health, right? And so we got a huge amount of free advertising for public health. And then what happened? Well, this is now sales of soda and other sugary drinks in the country. And as you can see, that regular soda consumption is going down pretty fast, starting around 2004. Looks like this has started to happen maybe before we did our action. And sales are increasing with, in some of these other drinks, like iced tea and sports drinks, but they're not increasing as much as soda is decreasing. So total consumption of sugary drinks is down. And in New York City, they're particularly going down. So we have our annual surveys of adults in the blue line here, and then we have surveys we do of teenagers every other year. And this is the percent of people who say they drink one or more sugary drinks per day. And as you can see, we've dropped from 36% here to around 23%. So it's about a third reduction. And here we had almost the same in teenagers. So big drop-offs in just a few years in consumption in adults and teenagers. And then what happened to obesity? That's what we were trying to respond to here. This is measurements of kids in public school in New York City. Starting in the 2006-07 school year, we started weighing and measuring every kid every year. And from that point to here, we got about a 5% reduction in the percent of kids who are obese. So that's not a big reduction. Don't be fooled by the scale. It's just a tiny drop-off. But what's exciting is that in the 30 years before this, we had this really rapid run-up. So finally, we reached a tipping point, and we're going in the right direction on obesity. We're not going down nearly fast enough, but we are going down in children. That's children now. What about adults? In adults, we haven't had so much success. Obesity rates are still rising in New York City. The rate of rise is slowing down a bit. And remember now, these people, as adults, many of them were much heavier as children than people before them because their cohort is aging. So I suspect we're going to have a bit of a lag, but I do think there's some sign that we may be tailing off this. We'll see. We'll have to follow this more. That's where we are with obesity. What about health more generally? What about the things that might be impacted by both the smoking work and the healthy food work we did? Well, remember I said the number one killer as far as diseases in New York City when Tom Frieden first came in was ischemic heart disease. So we saw about a 40% decline in mortality rates from ischemic heart disease during this period. Now I should be clear, ischemic heart disease mortality rates have fallen across the entire country during this period. But they fell faster in New York City than they did in the rest of the country. And then what about life expectancy, the one that I started out with? During the Bloomberg years, life expectancy at birth increased by 3.2 years, from about 78 to about 81. And in the US as a whole, they increased 1.8 years, from 77 to 78.8. So now there's a gap of more than 2 years in life expectancy at birth between New York City and the rest of the country. Or as Mike Bloomberg likes to say, if you want your friends and relatives to live long, healthy lives, tell them to move to New York City, right? But it's not just a joke. It does say that there's something about the environment of New York City that is helping people live longer, healthier lives. Now, I need to be honest here. The health department cannot claim credit for all of this increase. But I do think we can claim credit for some of it. That very sharp reduction in smoking rates that we expected might save tens of thousands of lives, you would expect to start to be reflected by improved life expectancy. And sure enough, we are opening up this gap. And this gap, by the way, is the largest gap between New York City and the United States in history, at least in history that's recorded going back to the 1800s. So something quite different is happening in New York City right now. So that's pretty much the story. And let me now try to draw some lessons which I think are important for big cities like New York City, or for that matter, for public health elsewhere. First is one that I would have started out anywhere, even before this story here, and that is health does not equal medical care. If you pick up a newspaper today or you see a story on the news about health, they're almost always going to be talking about medical care. They're not going to be talking about all the things we can do as a society to prevent people from getting sick in the first place. And that's why we're spending so much on medical care and we're not getting health out of it, because we've forgotten about all the different things we can do other than medical care to get health. The second is we can apply these environmental strategies to today's health problems. That's not just a concept that'll get us out of infectious disease epidemics, that if you put people in a healthy environment, they're healthier. Or the way that I like to phrase it these days is we want to make healthy choices easier. And we want to make unhealthy choices maybe a little bit harder, but people can always do things unhealthy. There'll always be plenty of them. But making healthy choices easier is the simplest way to explain this. Then, you know what? Health is political. When I say health is political, I don't mean in fights over Obamacare. That's political too. But the fights that I just talked about here are like fights against the tobacco industry or fights against the soda industry, fights with industry that is selling products that are bad for people's health. They will always resist any public health action, even if they can accommodate and still make a good profit. So the beverage industry sells a lot of beverages which don't have sugar in them. And they're going to do fine when we reduce our sugary drink consumption. They were already adapting. They still will resist that, and so there will always be a certain amount of political conflict to health. And it's always been that case back from Edwin Chadwick's day that public health is political. And then finally, a local government can lead. Before this time, most people assumed that if there was any level of government that was looking out over our health, it was the federal government. They're the ones that have all the data, they're the ones that put out all these reports, people know what the CDC is, they can see the big picture. But I think we all know now that the federal government is paralyzed in partisan warfare. The federal government can't do much these days. People did not have that much expectation for a local government. People thought local health departments were about restaurant inspections and rat control. But what my predecessor, Tom Frieden, showed is that a local health department can actually take on today's leading health problems and win. And I think that's where the excitement is in public health right now. It's in local government, and that's where you're going to see a lot of innovation. We are seeing it, and you're going to see it more in the future because many people have looked to the example of New York City and are copying them. They're looking to New York City in terms of the process it went through, but also with the specific actions that take place. So that the smoke-free air rule is spread across much of the country. Calorie labeling is going national. The soda tax idea has percolated, and as you may know, that passed in Mexico. It passed in Berkeley, California, and there are many places around the rest of the country that are now taking a lesson from Berkeley, and so that soda tax may appear somewhere else later on. So these kind of ideas will carry on, and a locality setting an example can lead in a way that the federal government can't. So that's the story of what happened in New York City. And I thought this was important enough to try to talk about it more. And so, as Dr. Wyckoff mentioned, I put him in a book called Saving Gotham that tells you the story that I just told you now, but more behind the scenes. How did we end up making these decisions, and how did we respond when we were sued and that sort of stuff. It's a fun story to tell. It's a fun read, and it teaches people, I think, at the end, what the lessons are of public health. So that's my story, and I'll end there and be happy to answer any questions.
All right, so just raise your hand if you have a question. I'll ask you one, Tom, though. In retrospect, could you or should you have run a counter-media campaign to the soda industry when you were trying to do those initiatives? Should you have been putting billboards up and signs on buses and so on?
Well, we did have messages that said they were pouring on the pounds. I think one mistake we made was in underestimating the public relations aspect of the policies. We thought if the Board of Health could pass it, we're done. But I recognize that the public's opinion ends up filtering into the way that judges read cases and the way that everybody makes decisions. And so we should have had a more thoughtful, more organized public relations aspect to our policies. I also recognize, though, that we had a very limited time when we had Mayor Bloomberg, who was willing to stick his neck out for public health. And we were going to have to do everything we could before then, and sometimes that meant we needed to move faster than we otherwise would. So I should.
how on earth did you ever get past the tobacco lobbies?
We didn't, let's see, I guess the smoke-free air rule was passed in the city council with a lot of opposition from the restaurants who were supported by the tobacco industry. But Mayor Bloomberg made it clear to everyone that this was his top #1 legislative priority, that's remarkable that an elected official would take a public health issue and say, this is my #1 legislative priority. And so the city council members knew they needed to work with this mayor for at least 8 years. And so they were willing to let him win on this one, although it was a tough battle.
Hi, thank you for your speech. I have 2 questions. The first one is that after you mentioning these 3 battles with the soda industry, what are they doing now currently in New York City? Are they fighting back again? Are they thinking new strategies? I don't know if you're aware if there's new policy or new ideas coming up to continue this battle. And my second question is, how has the role of Commissioner of the Department of Health in New York City have influenced or inspired your current role at your new NGO public good project, which focus on media campaign for public health problems? Sorry.
Thanks. So to answer the first question, the current City Health Department is still running media campaigns, pouring on the pound equivalent, warning people about the risks of sugary drinks. They have not put forward any policy initiatives. It's a different mayor, a different city council. They don't have as favorable an environment as we did, but they are trying to continue to work on this issue. As to your second question, I think we did show in New York City that messages in the mass media work for public health, and in the same way that they work for companies that want to sell products. The soda industry spends at least $1 billion a year advertising. They wouldn't spend that if it didn't work. And if they can use that technique, well, so can we. And so that's the idea behind my current organization, the Public Good Project, that we can use mass media messaging to address individuals and their personal risk, but also to help move the entire society towards a healthier society. And we have our first pilot campaign in this region that's Live Sugar Freed, if you've seen it. That's our first demonstration of what we can do, and we're in the middle of it right now, and we'll see soon what impact that's had.
It seems to me you weren't a bureaucrat at all. You were more of a leader of a movement. 5,000 people in your agency, middle-class salaries, life can be a grind in New York. How did you inspire them? In-service trainings, Fridays off to go to court hearings, an internal newsletter, to feel they were part of something bigger. One of our public health leaders went down to Nashville and took a model here at ETSU of working with community groups and forced all the local health boards to start doing that. Did you have some kind of internal leadership program for 5,000 employees?
Yeah. That is a really good question, which I have not been asked before. And I do think that you were right. A lot of running a big organization like that is about inspiring the staff. Unfortunately, in much of government workers are constantly given the message that they are just bureaucrats and that they're not important and that they're held in low esteem. And so simply communicating to the staff that they are professionals doing important work and saving lives. I tried to do that at every opportunity I could. I did have an internal blog, which I blogged every 2 weeks during the entire time that I was health commissioner. And what I would do is I would meet with one particular subunit of this huge agency and just have them tell me what they did. And then I would write a blog about it and talk about all the wonderful stuff that was. And then everybody else could read about it. And in this large agency, many people had no idea what another part of the agency was doing. So it served as an educational purpose as well as something that gave people deserved recognition. And the other thing I did was just with my own direct reports, the deputy commissioners, was I said, when I bring you on, we're going to spend a lot of time in the beginning to making sure that we fully understand what the strategy is. We're on the same wavelength. And then after that, I'm going to back off and let you run your unit. And so everybody has more job satisfaction when they're given the chance to make decisions. So there's nothing that I did here that I came up with the idea for myself. I am just now taking credit for the wonderful work of the wonderful staff I had. I can't say that I was successful in this, but I can say that I tried, and that was the technique I tried, was to make sure people had decision-making authority and were given recognition.
Do you happen to have any state or foreign nation as a benchmark?
Good question. There are, that could be done, but I have not compared that. I'm trying to think if anybody else has done that. I don't know the answer to that, whether New York City's life expectancy is moving in parallel with the countries that are healthiest, or whether it might be actually catching up. I don't know the answer to that, but I'll look at it.
With the tobacco in particular, did you see any other trends that changed, like utilization of parks or decrease in illicit drug use that followed along with that?
I can't say that it had any effect on illicit drug use. I didn't talk about it here, but we extended the smoke-free air rule during my time to make the parks and beaches smoke-free as well. My argument there was that the social acceptability aspect of it was important, and so that if a father took his son to the park to toss a frisbee or kick a soccer ball, the son shouldn't have to be getting a lesson in how to smoke. And so that did reduce smoking rates in the parks substantially. It didn't drop it to zero. Many fewer cigarette butts are on the beaches now in New York City. One spin-off that we did see, or at least that has been seen, and I believe occurred in New York City as well, is reduced asthma hospitalizations. As smoking rates go down in adults, then kids are less likely to be breathing secondhand smoke at home, and so they have fewer asthma exacerbations.
My question is, you had mentioned the green carts, the healthy bucks, and making healthy foods more widely available. Were those projects sustainable? And if they were, how have they remained sustainable? And if they are no longer being done, like how could you have kept them going, I guess?
So you cut right at the heart of how we approach public health today, and that is, many of our programs cost a lot of money, and so not only are they not sustainable over time because we run out of money, but they also can't be scaled up from a little group that we do them in initially to an entire population. So we tried to start from the beginning with something that would cost almost nothing and would have a permanent effect so that we would have that scalability and sustainability. The Green Card program cost the city essentially nothing, so that continues. That is absolutely sustainable. The Health Bucks program does force the city to come up with roughly $600,000 a year, and each year it is a bit of a problem, but the program does continue. And the Shop Healthy program does continue, so that's sustainable, but it's a small program, it's not scalable. We don't have the staff to go into every little bodega in all of New York City, and so that is an inherent limit into that. And that's the problem with this in general, is how do you, with very limited resources, affect a giant population in a sustainable way? It's not an easy solution.
Say one more question, I think.
This question comes from your live feed out of New Orleans, our daughter. One of our big questions, or one of her big questions, is what lessons from a political environment like New York under Bloomberg do you think would be effective in a place like New Orleans or Tennessee? What if political will is lacking?
Well, there's a general principle that public health, like politics, is the art of the possible. so that anyone in public health has to look over the political landscape and see what is possible. And it may be entirely different from what we did in New York City, where we had this great opportunity with Mayor Bloomberg. But actually, in some places, there may be some opportunities that for some reason we didn't have in New York. But in New Orleans, I know they recently passed a rule that made all the bars and restaurants smoke-free. That's going to be hugely influential because New Orleans is a big tourist town. And so tourists all over the country are going to experience maybe for the first time what it's like to go to a great music venue and not have to breathe in secondhand smoke. So although New Orleans is going to be a tough place to work on food issues, it is a place where you can work on smoking. And so I would say any public health person just has to sort of test out the waters and see where the political opportunities lie. There's a long list of things that we could do, and there's always something in there that you can do with that you have a political opportunity to do.
Well, thank you very much, Tom, and I know you'll be willing to stay around for a few minutes afterwards to ask some answer some questions. We have some parting gifts for you.
Okay.
First of all, we have a blue box.
Okay.
But more seriously, the title of honorary professor in the College of Public Health. So thank you very much.
Thank you all very much. Is this the blue plum that this town was
The blue
named?
plum, that's right. There's one blue plum in there. In your flyer, you have a couple of save-the-date notices for the spring. February 16th, we'll have a comedian as part of the Evening of Health, Wellness, and the Arts. And then on March 17th, as a Justice, Health, and Humanities lecture, Is There a Global Right to Health with Better Global Governance? So thank you all for being here this evening. And again, thanks, Dr. Tom Farley.
Thank you.